Hello and welcome to WHO and today's virtual press conference on global health issues. It's Thursday, 10 April 2025, and we're here at WHO HQ in Geneva. Please, first of all, accept my apologies. We're having a huge delay today, but I hope topic-wise we can at least make it up to you. My name is Christian Lindmeier, and I'll walk you through today's press conference. Now let me introduce the participants here in the room. We have first and foremost Dr. Tedros Adhanom Ghebreyesus, Director General for WHO. Then we have Dr. Mike Ryan, Executive Director for WHO's Emergencies Program. Dr. Maria van Kerkhoff, Director ad Interim for Epidemic and Pandemic Preparedness and Prevention. On her side is Dr. Abdi Rahman Mahmoud, Director Interim for Alert and Response Coordination. Then we have Dr. Tana Vulic, Executive Officer for Universal Health Coverage and Life Course. And to her side is Dr. Daniel Thornton, Director for Coordinated Resource Mobilization. On the other side of Dr. Mike Ryan, we have first Dr. Kate O'Brien, Director for the Department of Immunization, Vaccines and Biologicals. Then we have Dr. Calypso Chalkidou, Director for Health Financing and Economics. And last but not least, we have Dr. Rudy Eggers. He's Director for Integrated Health Services. We have a number of colleagues online who I will introduce when we come to it, but to mention one, we also have Dr. Rick Peperkorn. He's the WHO representative in the occupied Palestinian territory. With this, enough from me, and over to Dr. Tedros for the opening remarks.
Thank you, Christian. Good morning, good afternoon, and good evening. At our last media briefing, I spoke about the impact of recent funding cuts on global health. Since then, WHO has compiled feedback from more than 100 countries to understand that impact and the support of those countries need to mitigate it. The results show that severe disruptions to health services in 3/4 of countries and closures of health facilities in 1/4 of countries. We also see increased out-of-pocket payments for health care in 1/4 of countries. They also report job losses for health and care workers and disruptions to information systems and the supply of medicines and health products. In response, countries are revising budgets, cutting costs, and strengthening fundraising and partnerships. WHO has been working with countries for many years to support them to transition away from aid dependency to sustainable self-reliance based on domestic resources. We are now supporting countries to accelerate that transition, to avert the health impacts that these sudden and unplanned cuts are having. For example, South Africa's parliament has approved an additional $1.5 billion for its health budget this year. Nigeria has allocated an additional $200 million to health in its 2025 budget. Kenya's Health Ministry has requested an additional $250 million from the National Treasury to support health services. And Ghana and many others are also taking steps to bridge their financing gap. Countries are asking for WHO support for innovative fundraising and targeted technical assistance, and WHO is working to provide that support as best we can. There are several principles that we advise countries to follow. First, prioritize the poorest and prevent exposing them to impoverishing out-of-pocket health spending. Second, protect health budgets and resist reductions in public health spending. Third, donor funds should be channeled through budgets instead of parallel donation systems and aligned with national priorities based on one plan, one budget, one report. And fourth, avoid cutting services or closing facilities and absorb as much of the impact as possible through efficiency gains in health systems. These can include improving procurement, minimizing overheads, pooling purchasing of goods and services, and using health technology assessment to guide decisions on which services and products provide the biggest health gains for the money. There are also several tools that countries can use to generate new sources of revenue. In the short term, immediate measures include introducing or increasing taxes on products that harm health, including tobacco, alcohol, and sugary drinks. Countries including Colombia, the Gambia, Philippines, South Africa, Sri Lanka, Timor-Leste, Thailand, and more have all introduced such taxes in recent years and seen consumption decrease and revenues increase. In the long term, countries that don't already have social and community-based health insurance can introduce it, in which individuals or families contribute a small amount to a fund which finances health services. Not all of these measures will be right for every country, especially countries that have weak tax collection or a large unregulated informal sector. These countries will require significant loans from development banks at concessional rates and the right terms. WHO is working with affected countries to identify which measures are best for them and to tailor those measures accordingly. Now to Gaza, where a complete blockade since the 2nd of March has prevented all food and medicine from entering into Gaza. In addition, in the past week, 75% of UN missions within Gaza have been denied or impeded. This blockade is leaving families hungry, malnourished, without clean water, shelter, and adequate health care, and increasing the risk of disease and death. WHO took advantage of the precious ceasefire to resupply the health system and our warehouses. After 6 weeks of blockade, those supplies are dangerously low and will run out in 2 to 4 weeks unless the siege is lifted. 180,000 doses of routine childhood vaccines, enough to supply and protect 60,000 children under the age of 2, have not been allowed to enter, leaving newborns and young children at risk. Since the breakdown of ceasefire, almost 400,000 people are estimated to have been displaced again, with no safe place to go, and almost 1,500 people have been killed, including 500 children. The health system is only functioning partially and is overwhelmed. Meanwhile, healthcare continues to be attacked. Since the conflict began in October 2023, more than 400 humanitarian workers have been killed. On the 23rd of March, the Israeli army attacked a medical and emergency convoy, killing 15 health and humanitarian workers. Despite security risks, access restrictions, and dwindling supplies, WHO is staying in Gaza and will continue to deliver supplies, train health workers, support emergency medical teams, medical evacuations, surveillance for epidemics, and primary healthcare centers. Yesterday, WHO and our partners evacuated 18 patients and 29 companions to Norway, Malta, Luxembourg, and Romania. However, more than 10,000 other patients are still awaiting evacuation. WHO calls for the urgent lifting of the aid blockade, the protection of healthcare, unimpeded humanitarian access across Gaza, the immediate resumption of daily medical evacuations, the release of hostages still detained in Gaza, and above all, a ceasefire. Peace is the best medicine. Now to Myanmar. 10 days after the earthquakes that hit Myanmar, over 3,600 people have been reported dead. 5,000 are injured, and almost 200 remain missing. Across the affected areas, people continue to face significant health challenges, including trauma-related injuries, mental health issues, and lack of access to care for non-communicable diseases, including diabetes and cardiovascular disease. With limited access to safe water, sanitation, and hygiene, there is an increased risk of disease outbreaks, including cholera, malaria, and dengue. 5 health facilities have been destroyed and 61 damaged. WHO and our partners are strengthening disease surveillance, and we have deployed experts to support response operations. So far, WHO has delivered 140 metric tons of specialist medical supplies, and more is expected to arrive from Dubai today. These supplies are being used by mobile clinics, providing emergency care to the affected communities. 15 emergency medical teams have also been deployed, made up of volunteer international health professionals. To support our work, WHO has launched a flash appeal for $8 million, and we ask countries, philanthropies, individuals to contribute, including through the WHO Foundation. Late last week, WHO convened more than 350 experts from 15 countries to test for the first time a new initiative for deploying and connecting health expertise during health emergencies. Knowledge and people, software and hardware. The two-day simulation, called Exercise Polaris, tested WHO's Global Health Emergency Corps, a framework designed to strengthen countries' emergency workforce, coordinate the deployment of surge teams and experts, and enhance collaboration between countries. The exercise simulated an outbreak of a fictional virus spreading across the world. It was a rare opportunity for governments to test preparedness in a realistic environment, where trust and mutual accountability were as critical as speed and capacity. The exercise showed what worked well, including rapid information sharing and coordination of surge responses. It also showed what needs to be strengthened, including connections between technical leaders. Exercise Polaris reaffirmed that all countries must continue investing in their emergency health workforce and in scalable mechanisms that can expand rapidly and in a coordinated manner during crisis. Finally, today, WHO issued our first guidelines for the diagnosis, treatment, and care of meningitis. There are an estimated 2.5 million cases of meningitis globally each year. Many viruses, bacteria, fungi, and parasites can cause the disease. The most dangerous form is bacterial meningitis, which kills 1 in 6 of the people it strikes and leaves many others with lifelong disabilities. These new guidelines are designed for health workers to use and will help to save lives, improve long-term care, and strengthen health systems. They also contribute to the global plan to defeat meningitis by 2030. Christian, back to you.
Thank you very much, Dr. Tedros. Let us now open the line for questions. To get into the queue, please use the raise your hand icon to flag your hand and then unmute when it's your turn. And the first question goes to Nina Larson from AFP. Nina, please go ahead.
Yes, hi. Thank you very much for taking it. I was hoping that you could say a little bit more about the impact of the cuts on WHO itself, and then also given the state that you described at the beginning here about the what seems to be a very fragilized global health system. If you could say if that is adding to the urgency of completing a pandemic agreement this week, and how you see those discussions proceeding, and if you expect them to complete this week or if you expect them to continue. Thank you.
Thanks, Nina. I think that's touching upon a large range. Mike, do you want to start?
Yeah, Tedros may wish to come in. Yeah, I think when we consider cuts and we consider everything else, I think we need to be very cognizant of the fact that within an organization like WHO, there's always an opportunity to evolve structures, to evolve our budgets, to be more efficient. I think today of the people in Myanmar, I think today of the people in Gaza, I think today of people around the world who've lost their HIV therapy or their TB therapy, or children who haven't been vaccinated dying of measles. And in the hierarchy of suffering, any suffering at WHO is in the halfpenny space compared to what people around the world are suffering. However, we recognize that we're in a situation where, with the advice and in cooperation with our member states, we need to contract the amount of money we absorb as an organization in order to do the work we do with our member states and in the field. And we're doing that. And we're approaching that very, very responsibly in terms of cost containment, resource mobilization, looking at the priorities of the organization that we already set with our member states for a 5-year cycle, which would start in January next year. Within all of those deliverables, we are working at all levels to prioritize those deliverables, to work with the member states to agree what is the adapted work we will do, what is essential and must continue, what can be scaled back or postponed a little, and what can actually stop. And in the end of the day, we have to talk about what we can't do anymore, while trying to maximize all that we do. We've also got to look at the model of delivering that in terms of how we're structured, in terms of organizational design and how that's delivered. And that's something we're looking at as well. We're looking at our budgets and where that budget is spent. Is it spent here in Geneva? Is it spent at the countries? How we utilize our partners outside. Are we using our partner networks? You saw in the exercise Polaris, we're leveraging our partners to work more with us, so we don't have to expend as much resources, and our member states and their wonderful institutions can pick up more of that burden. So much is happening. It's happening in a very compressed period. You know, we're doing a lot of organizational work and evolution in a compressed period of time. And because of that, many of these processes aren't sequential, aren't linear, they're happening at the same time. And you know, we have to be honest, that's causing stress within the organization, and I'm really sorry, and for our own staff, in the sense that as things move like this, it's very easy for people to become disrupted and unsettled. And I have to say, I admire the staff of the World Health Organization and the way they have faced this difficulty with huge courage, but also with the needs of the people we serve right at the center of their concerns. And I believe when you focus on the people that you serve, you tend to find ways to get that done better and get that done more efficiently. So I'm really pleased with the process so far. We have some deadlines. We have to have a new budget on the table for the World Health Assembly, and in reality, in advance of the World Health Assembly, so the member states can consider it. And in line with that new budget, there will have to be a new set of priorities and obviously an organizational design that can deliver that. We hope to deliver that on time. We will deliver that on time. If I'm looking to the man to my left, we will be delivering that on time. And the organization, the stimulus for this is obviously something that we didn't want. Neither did health systems in the countries need this stimulus. The good thing is our organization, through many years of transformation, has become quite agile, and we've become quite adaptable. And similarly, at health systems at national level have actually had to adapt to a lot of changes in the international financial situation. They've seen donor funding dwindling over time. They've had to look for other sources of domestic financing for their health systems. So in a sense, the team here in Geneva, working with Dr. Tedros, have been working for years. In fact, I think part of Tedros' manifesto coming in was to transform the way health systems were financed. So this stimulus is not welcome because it introduces a level of sometimes panic to the process, and everyone gets very scared. But I think the outcome of this, as was DG said in his speech, is an acceleration of what's already been done. And we may be able to come out at the end of this as an organisation, but also as health systems, in better shape. But not because of this stimulus, because the system, our systems and government systems have already been adapting to the realities of a new world over half a decade or more. With regard to the pandemic agreement, yes, I mean, clearly the pandemic agreement is not a panacea. It deals with the future pandemic. It doesn't deal with all of the issues that concern people's health around the world. But there is no question that having a framework for cooperation between sovereign states when it comes to the next pandemic is the basis for collective action that is needed, it is required, and it will save lives. And it will be an efficient way to deliver. Recent modelling done with the World Bank and others looking at financial impacts of pandemics and annualising the cost of pandemics over many years show that if any agreement or any action or any investment were to shift the trajectory of the next pandemic by 1% or more, it would pay for all the preparedness activities that are envisaged. If someone asked you, if you give me 1%, if you move or change your behaviour 1%, you're going to get all of the resources you need to be able to live your life as you want. You'd say, wow, only 1%. So that's really where we are. Small changes in the trajectory of the future pandemic will save hundreds of thousands, if not millions of lives. And the member states are downstairs right now. They're negotiating. I must say they're incredibly hard-working people. They've been here every night this week until after midnight. They're doing their best and they're making steady progress. But there are difficult issues on the table, and this is where we all have to respect the sovereignty of each nation to approach a negotiation coming from their sovereign position and then seeing what they can do to work together. This agreement is not an agreement between WHO and nations. This agreement is an agreement between sovereign nations for collective action, which WHO will obviously support and facilitate depending on what they agree. Nothing is ever won until it's won, and nothing is ever lost until it's lost. So I won't presume to make a calculation as to how far forward we are. But I can tell you as a public health practitioner, having a framework that brings nations together and plans for the next pandemic will save thousands, if not millions of lives. Tedros.
Thank you, Mike. I think Mike has covered most of it, but I just wanted to focus on the impact on WHO. Of course, in my speech, I focused on the impact of the countries affected because of the termination of the aid. But as you know, WHO has also been affected. We actually saw this coming. And as Mike said some years ago, this is in 2017, 2018, one of the major risks we have identified, not actually one of the major risks, the major risk we have identified was WHO's reliance on few traditional donors. And we said at that time, we need to stop this. Because if any one of the traditional donors withdraws, we may not be able to absorb the shock. So that's why we have decided at that time, as part of the transformation, to broaden our donor base. And we have developed several instruments, for instance, the investment round, which is starting to deliver. The WHO Foundation was established, which is starting to deliver. And also we asked our member states to increase the membership fee of the 194 countries, which broadens the donor base. And of course, we saw it coming, although we didn't expect that it would be the US, but we knew it could, any one of the traditional donors could do that. And that's why we had the instruments. So the solution going forward is to accelerate the implementation of the instruments we have designed to broaden the donor base. And the outcome of the implementation of this reform will be a WHO which is stronger and even more empowered that can absorb any shocks in the future. So this is something we have actually identified as a problem, and which we have instruments to tackle. Then it's a matter of accelerating those instruments. And then on the changes we're doing in order to address some of the acute challenges, as Mike said, we're doing prioritization, trying to focus on core value, and WHO will definitely be right-sized, sharpened, but we can make it more impactful as well. So that's what we're doing, and I hope this is an opportunity for WHO to emerge stronger and more empowered. So the prioritization and so on is also another area that we hope will help us in strengthening the organization. And then the last on pandemic agreement, I just wanted to add only, and just say what actually Mike said. The member states are working very hard, late into the night, and so impressed actually, and listening to each other and addressing the concerns that are coming from member states and finding a middle ground. And I think with that kind of commitment, I hope they will reach a deal. And but what I see, the hard work and so on, is very impressive, and I hope they will reach a deal. They should continue to listen to each other and find a middle ground, of course, but I hope they will do that. Thank you. And Christian, back to you.
Thank you very much, both Dr. Mike Ryan, Executive Director, WHO Emergencies, and Dr. Tedros. Next question goes to Carmen Pound from Politico. Carmen, please go ahead and unmute.
Thank you so much, Christian. I just wanted to ask if there's been any outreach to the White House from the WHO for talks about the withdrawal. Obviously, we talked about this in the past, but the U.S. president has seemed to leave the door open for that. So I was wondering if there's been any more on that in the last few weeks, if there are any talks planned with the U.S. about what they would want to continue staying in the WHO. And the other thing I wanted to ask was about the Ebola prevention and response. There's been some confusion here and some sort of like contradictory statements about whether the U.S. is still participating in that. And the last I heard was that that was still the case, that the U.S. was still, paying for Ebola prevention and response in Uganda. So I was wondering if the WHO is seeing that. Is there any cooperation, for example, still ongoing between the U.S. and the WHO and the response to the Uganda outbreak, for example? Thank you.
Thank you, Carmen. For those, let me see where we start. Those on the Ebola or on the financing. Dr. Mahmoud, maybe for the Ebola.
Thanks so much. In terms of collaboration with USCDC and the US government, we've been working very closely with them both in Tanzania and Uganda in responding to the outbreak. But as I mentioned previously, it's not the response, it's the system that supports the system. So a lot of restriction on the core funding, whether the lab collection, the lab transport system, the IPC, the management of the waste, a lot of those funding have been cut. So technical collaborations have improved, and we continue collaborating with them. But the broader aspect, you can't isolate Ebola response from the broader investment in the health system. So that's the biggest challenge that we've been having. And it's taken, as Dr. Tedros mentioned, countries to submit resources to the budget, which takes some time. So the challenge we're having right now is while the collaborations have been improved, both at the country and also with our colleagues in Atlanta, but the broader investment required for the health to successfully manage an outbreak will require support in the point of entry, where thousands of people are workforce required, is the collection of the samples, is the supplies required for that. So I think the main challenge is happening is twinkling, wrinkling, small steps have been taken, but it's not enough to respond to a large outbreak like Ebola.
Thank you, Dr. Mahmoud. And Dr. Tedros, please.
Okay. On the engagement, no formal engagement has started yet, but informal reach outs we're doing. As you know, we have, I think, shared the three-pronged approach we have. One is the accelerating the implementation of the financing instruments we have. That's resource mobilization, which I said earlier. Second is sharpening WHO, make it more focused on its core mandate and reducing expenditure. And the third is engaging the US. So we still have it in our three-pronged approach, and we're engaging informally, but no formal engagement has started. What do they want? I mean, from what they want, if it's in the executive order, there are clear four things. I think reform, payment. They also mention about COVID management. And the fourth, I think, is WHO's independence. So these are actually good reasons to stay than to leave. I think I said it in the past. When it comes to reform, WHO is doing the largest reform in its history since 2017. It means we are open to reform. So if reform is an issue, then they can bring it, we can consider. Because we're receptive, that's what we're doing actually for many years. And then the second on payments, of course, this is decided by member states. But if they want to pay less, that's actually what we have been doing since 2017. Working for broader donor base means the contribution of the large traditional donors will decrease, but this will not come like tomorrow or after tomorrow or next year, but in the next 5 to 10 years. The contribution of the traditional donors will significantly decrease based on the approach that we started in 2017, because our donor base will be broad. So if that's what they want, and that's what we have been doing since 2017, and the instruments we have designed are actually starting to deliver. So it's better to stay inside and then help in making sure that the changes for sustainable financing that we started actually succeed. So it's not a good reason to leave. And then the third on COVID management, of course, we tried our best. We have done our best, and we learned lessons from the COVID, and we're implementing lots of changes. As you know, the BioHub we created here, the Berlin Hub, which is to improve surveillance, the Pandemic Fund with the World Bank to improve financing of preparedness, the UHPR, or the peer review mechanism, and you name it. So that cannot be an issue. We did our best, and we're also improving some of the challenges we have all seen as a global community. And then, of course, the fourth on independence of WHO. The first one is attached to this, the reform we're doing, and also in our actions. I think what we're doing is to make WHO more empowered and independent, and if that's what they want, they can stay to contribute to make WHO more independent. But as many of you know, when the answer is no, especially something that contradicts the values and principles of the organization, we have said no many times, and that's publicly. So we are clear about our values and principles, and we try to be independent, no matter the consequences that may have, because we say no. And if that's what they want, that's exactly what we're doing. We have been doing the last few years. So this is, I think, as I said earlier, the four in the executive order are good reasons to stay, and I hope there will be some formal engagement for a very honest and candid dialogue for the US to come back to the World Health Organization. I said it many times that the US withdrawal from WHO, it's a lose-lose. It's in the best interest of the US to stay in WHO. It's a health security that keeps the US safe and the rest of the world safe by being in WHO. And it has also many other benefits for the US to stay within the WHO family. And all the investment has been doing is in its own best interest. And that's what we believe, and I hope they will reconsider and join reconsider and join the WHO family. Christian?
Thank you very much, Dr. Tedros. One hand went down, so the next question goes to Kerry Cullinan from Health Policy Watch. Kerry, please go ahead.
Thank you, Christian. I see that there's 193 million outstanding members' assessed contributions. So I just wondered whether it was going to be possible for the WHO to get that money, because obviously it would help a lot with your financial situation. And then a clarification on the earlier question on the pandemic agreement. I wasn't clear that if agreement is not reached tomorrow, is there a window of opportunity for them to continue with the talks up until the World Health Assembly, or is it a hard stop tomorrow? Thanks very much.
We seem to be one topic only today. We'll want to go over to Daniel Thornton, maybe. Want to start with Mike Ryan? Right, Dr. Mike Ryan, please.
Daniel, speak to the issue of assessed contributions. But my understanding is that assessed contributions or membership fees from member states are to be paid up until the moment of departure from the organisation, so therefore any arrears should be paid in advance. That's the legal position. The reality of what may happen, I think, if Daniel can speak to. With regard to the pandemic agreements, you specifically asked, just to clarify the question, Christian? Oh, if they don't agree, that was it, sorry. Thank you, Gibson. If they don't agree by tomorrow, the member states will do what the member states do. We have gone through 13 rounds now, and some of those rounds have been multiple meetings. And at any time that the member states require more time, the Secretary will do whatever it takes to get them more time, to get them venues, to create the conditions in which they can negotiate. The reality is we're up against that time now. And if you consider that many member states will have to consult their capitals or will have to go back and have a discussion with higher authorities, the practicalities of having more negotiations before the Assembly and then going back to capitals so ministers of health can come here. Remember, the meeting in May, the World Health Assembly, is classically a meeting of ministers of health. It often involves heads of state, quite frankly. So the people who will make the agreement at the Assembly are at a higher level. So you can imagine that the sooner negotiations can be concluded, the sooner we can prepare that process. They don't have to have every I dotted. They don't have to have every comma agreed. There can be a few little things that need to be resolved. For example, the text will require a kind of a legal oversight, and the legal teams in countries and here will have to, they term it a legal scrub, where they just have to look at the language and how it's used and the terminologies and the spellings. So there is work to do to prepare for the adoption of an agreement. So therefore, realistically, we are talking about this week till midnight. If they want to add on more time this week, they can do that. I'm sure Tedros will turn around, and if they want to stay and do it next week, they'll be here. That's their call. The member states will have to make a judgment themselves of how close they are. The negotiators downstairs are not WHO negotiators. The negotiators downstairs are negotiators assigned by 193 sovereign states, right, or 192 sovereign states in this case. And they will decide what happens next, and we will facilitate whatever they wish. We will obviously offer them advice around timelines and what's realistic and what can be done in advance of the Assembly. So, as Tedros said, they're making progress, and we will wait till tomorrow. I'm always someone who's very reticent to admit that you won't make it and then add on more time, because in my world, work fills time, and if you make more time, the work will just stretch out to fill that time. Now, there is a time that's needed, and there are real issues. Member states, people may mock them and say, oh, there's only a word here and a word there, and why can't they agree? Some of these things have meaning legally, they have meaning politically, they have meaning ideologically. And getting member states, the great thing we should celebrate is that there are currently over 190 member states in a basement trying to find a way to work together. trying to find language that will protect 8.5 billion people from the next pandemic. We should be celebrating the very fact that they're in the room, given everything else that's happening around the world, geopolitically and geoeconomically. This is a real shining example of our leaders, the people you all out there vote for, the people who you call your governments, are desperately trying to find a better way to do business together when it comes to protecting the world's population from the next pandemic. They should be commended for that. They should not be mocked for making slow progress. Things that matter sometimes take time, because if they're done properly, they will last a long time. And the more care we take now, the more chance we have to have a robust agreement that all member states will buy into and will live by and abide by. And for me, that's a very important process. For us who work in the front lines, I look at these texts and you can say, oh, what difference does it make? It makes a huge difference, because what it does is it sets out the rules of the game between member states. It sets out the aspirations of the member states, and it gives us working in public health the kind of support we need. It is exactly the same as a police force or any other thing you want to do. If you operate outside rules, then the rules are only as good as the rules I made up yesterday. The great thing about an international rules-based system is we all agree how the game is played. And we really do need to play a better game in the next pandemic. And this is the way to do it.
Okay, I will take the assess contribution. On the assess contribution, the member states have agreed to increase the assess contribution or membership fee in 2022 by 50%. This is part of our reform, sustainable financing, as I said earlier. And the 50% is paid through installments. And the installments, the first installment was paid for the program budget 24-25 after the decision in 2022. So this has nothing to do with the US withdrawal. This is something that's part of the reform we started in 2017, and the decision has been made in 2022. The first installment has been done for the program budget 24-25, and we hope the subsequent installments will also be done in due time. I think the 50% is expected to be completed by, that's the 2030-2031 program budget. By the way, this increase of 50% agreed by member states is the largest in the history of the organization. The assessed contribution has been very constant until 2023, with slight increase, I think twice or three times, for a maximum of 3%. This shows the commitment of our member states to ensure sustainable financing for the World Health Organization, because that, I think, funding, membership fee, ensures WHO's empowerment. So we hope member states, as per their decision, they will honor their decision, or as per their pledge in 2022, they will honor their pledge, and that's what we're expecting. Thank you.
Thank you very much, Dr. Tedros. And now the next question goes to Priti Patnaik from Geneva Health Files. Priti, please go ahead.
Hi, thanks for taking my question. I was wondering if WHO wanted to comment on, the slew of tariffs that have been slapped across countries and how that impacts pharmaceutical supply chains, not just medical products, not just medicines, but also other medical products. Has there been an assessment of what it's going to, how it's going to affect your operations on the ground, for example, apart from increasing costs? Thank you so much.
Thank you very much, Priti. I'm looking at Dr. Chalkidou. She's Director of Health Financing and Economics. Calypso, please.
Thank you. Thank you. Yes, the tariffs are a big problem. And the problem is also that when it comes to sub-Saharan African nations, some of the poorest nations with the smallest economies, the weakest economies, seem to have been the worst hit. So countries such as Lesotho, Madagascar, Cote d'Ivoire, a large chunk of their GDP could be wiped out by the tariffs if they continue, if they're sustained. And these are the very countries where external aid, a large chunk of which does come from the United States, is also critical to finance their healthcare system. So some of these countries, up to 30 or 40% of their total spend on health comes from aid, and a large proportion of that is US aid. So it's unfortunately several pressures that are challenging and will affect the way these countries function. Now, tariffs are not, pharmaceuticals are excluded. However, most of sub-Saharan Africa is reliant on imports of pharmaceuticals. The continent is a net importer of pharmaceutical products. And so if you put this together with the fact that the more general financial crisis, devaluation of currencies, depletion of foreign exchange reserves, and very sticky inflation, if you put all this together, really the bill for importing pharmaceutical products is going to get bigger. And again, at the same time, we see institutions such as PEPFAR, USAID, who purchased on behalf of countries and donated, in fact, products for specific diseases, especially HIV, TB, malaria. Those sources are also now being frozen or paused indefinitely. So it is a very critical situation. Thank you.
Thank you so much, Dr. Jacquidou. And it looks like the next and last question goes to Jen Rigby from Reuters. Jen, please go ahead.
Hi there, thanks for taking my question. I just wanted to ask about the measles outbreak in the United States and if WHO would like to see any more action being taken, and also if WHO is working with or hearing from the US CDC about that, since I think we had a notice out at the end of March, so a little while ago now. So yeah, an update on that, and is enough being done?
So thank you very much, Jen. Measles outbreak, where's Dr. Kate O'Brien, please?
Yeah, thanks for the question. I'll just remind folks that measles is one of the most infectious viruses, and so measles anywhere is, in fact, measles everywhere. The U.S. is a country that had eliminated measles in the year 2000, which means that the only cases that are occurring in the U.S. are coming from importations of measles and then the spread of measles within the population in areas, subpopulations, sub-communities in the U.S. that have insufficient immunization rates to stop the spread of the virus. And also just a reminder that measles is a deadly virus. I think people forget just how sick and how dead that virus can make you. And so it's a serious illness, notwithstanding that not everybody who is infected with measles has a serious case. I think what is clear is that the U.S. is working to control the outbreak and to shut the outbreak down. It is a multi-state outbreak. There are cases, as we reported in our disease outbreak news report, there are cases in many states. Obviously, the center of it is in Texas. And the most important thing, and I think this has been clearly stated by many people, including the Secretary, is that the measles vaccine is the most important intervention to stop this outbreak and to end the risk to individuals who are not immune. So I think for any country, as long as an outbreak is going on, not enough is yet happening. We could only say enough is happening when, in fact, the outbreak has ended. I'll just point out also that we have had a huge increase in the number of outbreaks over the past couple of years, largely related to the backsliding in immunization that occurred over the period of the COVID pandemic. So there are 58 countries that have not just outbreaks, but what we categorize as large and disruptive outbreaks in the past 12 months, which is a substantial increase compared with the number of countries having large and disruptive outbreaks in the preceding 12 or 24 months. So this is not just about one country, it's about action being needed on the part of many countries to really get a handle on measles and to shut down measles outbreaks and to continue making progress to get to elimination, which every country has made a commitment to do. So I think those are the main points, and I think I'll just end those comments by just again reminding you that measles vaccine is an incredibly safe vaccine, and it's incredibly effective vaccine. 2 doses of measles vaccine confers upwards of 95% efficacy, and a single dose confers over 90% efficacy. So anybody who does not, who has not been vaccinated should certainly be doing whatever they can to get vaccinated, especially among young children who are some of the most at risk for severe consequences.
Thank you very much, Dr. Kate O'Brien, Director for Immunization and Vaccines and Biologicals. Thank you very much. With this, we've come to the end of our questions. Thank you all very much for participating. We will send the audio files and Dr. Tedros' remarks soon after this briefings. For all other questions, please write to mediainquiries@who.int. And with this, over from me and back to Dr. Tedros for the closing remarks.
Thank you. So thank you to members of the press for joining us today, and see you next time.